Sorry about that. So yeah, I did most of my shifts in the ER. It's a great experience. And then I decided to go back so that I was making the same amount of money as the rest of the RNs who were working with me in the ER. So I just kind of wanted, so my job is to just kind of go through what you guys learned this week in class, and just review it with you, answer any questions that you might have. There were some problems with the chat yesterday, but I've got it figured out. So if you have any questions, feel free to type them into the little chat window on the right, and I'll try to answer them if I can. My goal is to kind of review everything that you need to know to pass this portion of your exam in an hour. I'm terrible at it, and I never get through it all in an hour. It's just a lot of information, but I'll do the best that I can. So yesterday, so just so you know, it's the same material. Yesterday what I did is I went through the slides that your prof, Christine, who's awesome, posted. I went through each slide and kind of talked through and let people ask questions. When I was doing that, a couple of people were asking, you know, if there was any kind of more visual way of learning this stuff that wasn't quite just, you know, in the textbook, it's just words, right? It's just paragraphs and paragraphs. And so I made up this little mind map. So this information is all the same information that we did yesterday. It's just in a different format. So if you learn better by going straight through slides and with words on them and just kind of, you know, talking it through, you can look at that recording as well. But hopefully this will be okay for everyone, but especially for people who kind of like the more visual way of looking at things. Before I get started, I'm just wondering where you guys like it in terms of this subject, inflammation, if there's anything that you're really struggling with and want to go over, want to really focus on. If you have something like that, could you just throw it up in the chat for me, and I'll make sure that we hit that subject hard. I'll just give you a minute to do that. In the meantime, everybody's working as RPNs, correct? Or many of you are working as RPNs, but you all have your RPN degree, is that correct? Yes, Samantha, Tony, Haley. Awesome. Are any of you actually working right now, long-term care or acute care or anything like that? Yes, Kimberly, Tony. Where are you guys working? It just helps me to kind of have an idea of the experience you guys have, so that long-term care, Samantha, okay. Whew, it's a hard place to be right now. Peds, another peds. Okay, awesome. Rehab and OR. Where do you work, Tony? Toronto Grace. Okay. Clarity. Medicine. Haley, where do you work? What hospital? Oh, that's cool, Tony. Cataract surgeries. Okay, so that's good. Medicine, especially, that's a good place to start. You probably are just fine with all of this. So let's just give you guys, let's review the information that we need to pass this exam, right? Okay. So let me know, again, just click up if you have any questions while I'm talking. If I don't hear you, feel free to unmute yourself and just talk. It was great yesterday because of the few people actually talked with their voice, which I really like, but feel free to use the chat as well if you're more comfortable with that. Okay, so we're going to start really, really simple. We're going to talk about what inflammation is, what's the point of it. So really, when we think of inflammation, and that is totally spelled wrong, just ignore it, please. We think of something bad, right? Inflammation. But the reality is that it's there as one of our body's mechanisms to protect itself from injury, or a way that it gets rid of something that or neutralizing and diluting something that is trying to damage the body. So if you come up against a question that's asking you, what's the, oh my gosh, that misspelling is bothering me. If it's asking you, because you do get those really easy questions, these are kind of your main points that I pulled out of your slides that you want to hit on. It neutralizes and dilutes the damaging repair. damaging agent, and then prepares the area for repair. And we'll talk a little bit about that. Basically, the point is to get rid of this organism or this injury, right? And to control the effects, make sure that it doesn't have too much damage. And then, so the textbook kind of talks about these two different types of cell injuries. You have your lethal cell injury, sublethal cell injury. These are pretty explanatory, but you probably will come up against a question, so just make sure you have this straight down. Your lethal cell injury, lethal means death, right? So it's an irreversible cell death. This is caused by often it's caused by ischemia, right? So you have a lack of blood flow. If you look here, kind of put this little picture of a heart here, because it's a lack of blood flow to a certain area, and it's going to damage, that area, and usually cause necrosis. If it causes necrosis, it's lethal, right? Necrosis is cell death, so it's not, it's irreversible. Then you have this kind of sublethal cell injury. In this case, something has damaged the cells, but they don't die. Instead of dying, their ability to function properly is affected. So if you look here, I just kind of put this little picture. So for example, if you have a nephron, and it's damaged but not killed, it's going to stop working properly. It's going to stop filtering all of those substrates that it's supposed to be filtering through that loop of Henle and so on. And so that is still very serious. It's still a cell injury, but it's not a lethal cell injury, right? The cell hasn't actually died. So let's go back over to this lethal cell injury. So when we talk about cell death, you're going to see these two words, apoptosis and necrosis. And we just want to clarify really quickly. When we talk about apoptosis, we're talking about normal cell death. So for example, your red blood cells live for something like 21 days, right? When those cells die naturally, like they die of old age, we would call that apoptosis. That's not harmful. It's totally normal. We're not worried about that. On the other hand, when we have necrosis, this is a cell death that is, and you guys know this, you've seen necrosis, necrotic tissue at work, I'm sure. This is cell death that's caused by some kind of traumatic event or injury. Now, you had this little kind of chart, sorry, my computer froze, this little chart that was in your slides. And I find these a little bit intimidating because they're so wordy. So I just kind of pulled out what you really need to worry about in this. So these are kind of the main classifications, I guess, of necrosis, right? So you have your coagulative necrosis. Anytime you see the word coag or coagulative like this, it's referring to blood, right? So we know when we see coagulative necrosis, we're talking about ischemia. An example of that, again, is this myocardial infarct that I kind of talked about up here. The second kind of classification would be your liquefactive necrosis. You guys know from real life, you're going to see this coagulative necrosis probably a whole lot more. We call this one liquefactive because there are these, so when you have a bacterial infection, you have these enzymes that are released to break down that bacteria, but sometimes it breaks down the tissue around the bacteria as well and causes cell death. And you end up having this pussy kind of liquid substance. An abscess is a really good example of that kind of necrosis. Okay, so that's pretty easy to separate on a test, right? There shouldn't be any issues with that. I wouldn't worry about this caseous necrosis. It's just a specific kind of coagulative necrosis. One of the things I think I told the other group that I forgot to mention here is that, so because I've done patho at least twice, I think 3 times if you count all 3 programs, I'm usually pretty good at recognizing like which questions or which subjects are going to come up on exams and which ones, for example, if I've never had a question come up around this, caseous necrosis, doesn't mean it won't come up on your exam. I make no promises whatsoever, but you know, in the 3 or however many exams, or plus my NCLEX, plus I do NCLEX tutoring as well, you're going to hit these subjects a whole heck of a lot more, this coagulative, liquefactive, or gangrenous. So that's why I'm just focusing on those, okay? So when we're talking about gangrene, you guys have probably all seen this. We're talking about necrosis of an appendage. This is often caused by or related to coagulative necrosis, right? It's often caused by ischemia or a bacterial infection. It's just that when it's occurring in an appendage, we call it gangrene. The only other thing that I would pull out of this slide for you guys is knowing the difference between wet gangrene and dry gangrene. Wet gangrene being the one that has some kind of bacterial involvement, and then dry gangrene would just be your cell death without bacterial involvement. So for example, again, this dry gangrene, if you have some kind of peripheral vascular issue and there isn't blood getting to the area and it causes necrosis, we would call that dry gangrene. Whereas if you have some kind of infection that has caused necrosis, that would be wet gangrene. So nothing too complicated there. There was a nice little list of chart again of kind of causes, and each of those would definitely fit into like one of these categories as well. Don't worry so much about trying to, you know, be able to recognize the difference between, for example, hypoxia as a cause and hypoxia as, you know, a type of necrosis. The idea is that when you see the word hypoxia ischemia, you know we're talking about cell death related to a lack of blood flow, which I'm sure most or all of you probably know. Okay, so you know, again, cells can't get enough oxygen or glucose or what have you, and they die. Heat and cold intolerance, we're talking a burn here possibly, and frostbite, for example. Those are 2 good examples of how blood flow changes related on heat or cold, and how that can affect the ability of those cells to get the glucose and oxygen that they need and what have you, right? Electrothermal injury, we're just talking literally electrocution. You know, you're interrupting the nerves, the conduction of the nerve system. So for example, if you interrupt the ability of the heart to conduct its nerves, it's going to cause, you know, this fibrillation in the heart. You're going to end up with effects on your blood flow to the rest of your body, and again, you're going to end up with necrosis and cell death. I'm sure you guys know the difference between abrasions, lacerations, incisions, so I'll leave that to you. We're going to talk about microbial today, and this neoplastic, I wouldn't worry about that too much for this unit because you're going to have a whole unit, I think, on neoplasm and cancerous growths and so on later on. Okay, so before I move forward, does anybody have any questions about anything we just talked about? Just going to give you a minute to kind of throw it up in the chat, or feel free to unmute yourself if you have a question. We're good? Okay, I'm going to keep going. So this is kind of where we get into the nitty-gritty of the subject. I kind of went through the slides and organized this in a way that made sense to me, and I'm hoping that it will help you as well. So the body has 3 lines of defense. Okay, you have your first line of defense, which is basically your anatomical and, sorry, I just want to scroll out, your anatomical and chemical barriers. Okay, these are really common sense things like your skin, your mucous membranes. Saliva, urine, even your tears have enzymes or lysosomes in them that break down the cell walls of certain bacteria. These are things that your first line of defense are things that prevent that foreign object or foreign pathogen or whatever from entering your body. So when we're talking about your skin, we're talking about protecting your body, yes, against bacteria, but also against any kind of like perforation or abrasion, right? So a sliver or anything like that. So those are the things that are going to stop something from getting into your body. That's your first line of defense. And obviously this line of defense is non-specific. And when we say non-specific, we mean it's not tailored to any specific pathogen or injury, right? Your skin protects you against, well, hopefully everything. I mean, it's not going to, but it's going to, it's there to protect you against whatever it can. It's not specifically fighting a certain kind of pathogen or injury, right? So we have a second level of response or second line of defense that is also non-specific, meaning it gets a little confusing here because it does involve white blood cells and an inflammatory process, but it is still non-specific. It's not fighting against or creating immunity to a specific pathogen. It is just it is there to fight whatever breaks through this barrier here. Okay, so something breaks through what have you here. Now you have either a pathogen or an injury or something that has gone through that barrier and is in your skin or in your tissue. Okay, so now I just put this lymphatic system here as I find it helpful because that's where it's how we classify where kind of these white blood cells and the inflammatory, like where it's coming from. Okay, this is kind of where we're going to spend most of our time talking or reviewing today because this stuff is pretty simple and this is fairly quick. So just to go over this quickly, the third line of defense, this is where we get specific now. This is where our cells, our white blood cells, are creating antibodies that are specific to a pathogen that has broken through this barrier here. Okay, so I know that can get a little bit confusing. We'll kind of fly up to that, like back and forth as we talk. So hopefully it will help keep things clear. Oops, sorry, my computer's a little jinxy today. So when we talk about this inflammatory response here, okay, remember we said it's the second line of defense, it's non-specific. This is where we have those 3 phases that kind of where we, this is where we spent most of our time. Whoops, sorry. So with those 3 phases, this healing phase here isn't something you need to really worry about. It kind of makes sense. We'll talk about it later. It's really these 2 phases here, the vascular and cellular, that get really, really involved. And so we're going to go through those, hopefully really quickly. So let's assume we have some kind of, so we have some acute inflammation here, okay? Something has happened, regardless of that type of injury, whether it's bacterial, it's some kind of pathogen that has broken through that first barrier, or it's something mechanical, for example, a sliver or a stab wound or whatever. Your inflammatory response is going to be the same. So you're going to have that vascular and cellular response. Okay, so we're going to go through kind of the steps of, let's start with the vascular. Do not get scared by this giant picture here. I'm going to go through what you need to know, and otherwise you don't need to focus on a large portion of it. So don't panic. So the first thing that happens is in the vascular response. Okay, we're talking vascular response, and again, that's the vascular response, which is part of the inflammatory response, which is part of the second line of defense. Okay. The first thing that happens is we have this little bit of what they call transient vasoconstriction. Anytime you see the word transient, it means it comes and goes quickly. You know that from likely from a transient ischemic attack, right? A TIA. Comes and it goes. So we have this transient vasoconstriction. It's not even really necessarily a part of the vascular response as much as it is your sympathetic nervous system's automatic kind of response to any kind of injury. So it's that fight or flight response that's kicking in and causing that momentary vasoconstriction. It's very, very fast, like come and gone sometimes within 2 or 3 seconds, and then we're moving on already to this more important, really, aspect of the vascular response, and that is where that cellular damage, whether it's bacterial or an actual physical injury, has caused or will trigger this fibrinogen, which is already in the blood. So fibrinogen is just, I think of it as a protein. I'm not even sure if it is a protein, but it's already floating around in the blood. You can see here, I'm going to just zoom in a little bit here. Don't get freaked out because you don't need to memorize this. This is just, sorry, my computer keeps freezing. Just a way for you to kind of see what's going on. So we're looking kind of right here at this. Oops. Oh, bloody Pete, sorry. Oops. Sorry, guys, I'm having a little bit of an issue. I don't know why my computer's kind of freezing up like that. Anyway, so the second thing it's going to do, or the more important thing, is it's going to clot at that site of injury. So you're going to have platelets that collect and clot at that site. And this fibrinogen is involved in that. It's already in the blood. And then you guys don't need to worry about all of this, but there's kind of this whole cascade that happens where thrombin comes in and it adds to the fibrinogen, and then it creates fibrin. And what that fibrin does is it kind of strengthens that clot. So here you've got this, these piles of blood clots, but once that fibrin and those fibrin strands build up, you can see them in this picture, they build up around those clots. I call it a spider web. It kind of creates this spider web around those clots and strengthens those clots. And that's actually the basis. That fibrin clot is the basis, like the platform for future healing. That's where we're going to build our new cells on later when we heal further. Okay, so that's our second, really the big thing that's happening first. I kind of don't count this as the first thing happening because it's just so fast, but this is the first major thing that's happening in the vascular system. Just so you know, the fibrin, when I say it provides like a base, it provides kind of like a surface for new capillaries to be built. And when I think the word angiogenesis is in your slide, so I just wanted to kind of go over that. When you see any word that ends in genesis, we're talking about the creation of something. Right? Anytime you see angio, we're talking about blood or blood vessels, right? And angiogram is an exploration of the vessels. In this case, angiogenesis is the creation of new blood vessels. This fibrin here is this fibrin kind of clot is very, very important for that, for creating kind of a platform for that to happen. So at the same time, And it is very, very involved, so we won't go into how it's all happening. But at the same time, you have these pro-inflammatory mediators that are released. Your slides talk a lot about histamine, which is great. There are other ones that are also being released, things like prostaglandins, bradykinins, leukotrienes. We'll go through those, but I think what's really, really important when we talk about histamine, I'm just going to go down, talk about histamine for a second. Histamine does these three kind of big things. And quite honestly, if you get stuck on an exam and you're not sure, they ask you a question about, for example, prostaglandins or bradykinin or anything, and you're not sure what that quote-unquote pro-inflammatory mediator does, go with these three things, because they pretty much all do these three things. First, they cause vasodilation. Okay, no problems there. We all know what happens when we have vasodilation, right? They also cause an increase in the capillary permeability. What that means is the vascular system in that site. Okay, so we're not talking about the entire system. We're talking about at that site where that injury has occurred. It definitely can be systemic, but for now, let's talk about it at the site where injury has occurred. You have this increase in the ability for things to pass through the outer membrane of the vessel or the venule, right? So capillary permeability means that well, we'll talk about what happens after. And then you have this third kind of aspect here, this smooth muscle contraction. You guys are really lucky because it doesn't come up really in any of your notes. So let's just skip it, because we're going to focus on these two main things, this vasodilation and the increase in capillary or vascular permeability. So what's going to happen when you have that increase in vascular permeability, an increase in and blood flow? So really, when you have this, sorry, I skipped that, but when you have these two things, this vasodilation and capillary permeability, you end up with hyperemia. Again, hyper, lots of, or too much, or over, and emia is always going to mean blood, right? So you have too much or lots of blood in that area. It's hyperemic or hyperemia. What happens when you have a ton of blood in one area like this? You can see in this picture, you have an increase in the filtration or hydrostatic pressure. So unfortunately, you guys haven't gone through the fluids kind of unit yet. And I find that once we've been working for a while, this is something that kind of flies out of our mind. We just kind of know, which fluids to give, and we're not really thinking about the pressures and what's happening. But we'll go through this in, I think, three or four units a little bit more closely. But for now, what we're talking about when we talk about hydrostatic pressure is the pressure that's exerted from the inside of the vein by, in this case, by this collection of blood and fluid and what have you, the pressure against the outside. It's pushing against the outside of that vein, or the capillary, really. When it's pushing like that, and remember we said we also have this capillary permeability, which means it's more susceptible to things passing through it. Normally it wouldn't, these things that normally wouldn't. What happens is all this pressure pushes the fluid out. So out of the vein, out of the vascular system, out of the capillary, and into this interstitial space or the tissue. This is why we end up with swelling at the site of injury, part of the reason anyway. So when we talk about this capillary permeability, there's a little bit of a note in one of your slides that talks about an endothelial gap. So if you look at this kind of picture here, and you imagine that this is like a slice of the vein, right? This is the outside, and this here is one it's kind of silly, but it's one endothelial cell. Obviously there would be way more than that. what happens is those cells, those endothelial cells, they contract. And when they contract, so they pull in, right? This is pulling in this way and pulling in this way. It creates these gaps in between the cells. And that's what makes the capillary permeable. That's what allows things that normally wouldn't go through to pass through. And when you have, again, you've got all that pressure from the hyperemia that's in here. Sorry, all that hyperemia that's in here pushing against, obviously, that fluid is going to come out. Now, there's one more thing that's going on in terms of those fluids and pressures that can get a little bit confusing. We are hopefully going to be able to explain that fairly easily. Okay, so part of what's happening is inside of those, I'm going to use this kind of drawing here. Okay, so this is, again, this is the inside of the venule, and this is the epithelium, and here's that gap we were just talking about. So what happens is that sometimes because of the damage that's been done to the area, the cellular damage, plus because of these growth and endothelial gaps, some of the proteins that are normally here, for example, albumin really is really what we're talking about here. Is we're talking about albumin. So albumin will escape either through these gaps, or it will escape just because this entire tubule is damaged, right? And so now you have these large proteins that are outside the vein, normally are in the interstitial space. So this increases what's called your oncotic pressure. For the purposes of this review that we're doing right now, just view oncotic pressure as the pressure that is pulling. So it's pulling fluid out of the out toward the large proteins. Okay, it's oncotic means we're talking about large molecules or large proteins. Okay, oncotic pressure, or the extracellular oncotic pressure, is because these giant proteins have leaked out into the extracellular fluid, and now it's not just that you're having all of this hydrostatic pressure pushing against here and causing all of that fluid to be pushed out. You also have this pressure now that's pulling the fluid out. Pulling the fluid out towards these larger molecules of these albumin, really. And so that's kind of what the book is talking about it when it's saying, you have those two forces that are kind of working with each other to pull fluid out of the vein and into the interstitium. And when that happens, of course, you guys know, you end up with edema, right? That's really what edema is. So we're going to come back to this little kind of blood clot guy here in a second, but I just wanted to kind of, when that happens, if you're pulling all of that blood or that extracellular fluid out, what's left inside the vein? Well, what's left inside the vein is largely red blood cells and larger proteins, but so in this case, your hematocrit would be fairly high, right? Your percentage of red blood cells in that vein that's left over in that venule is going to be thick. It's going to be high, so it's going to cause the blood to become very, very thick and viscous. And there are some other things that contribute to this nitric oxide that's coming from phagocytosis, which we'll talk about later, so don't panic. And also during the macrophage, some processes of the early processes of the inflammatory response, we are having nitric oxide released as well, and that's all contributing, we'll talk about it later, to this not necessarily problem of, but this thick kind of blood or viscous blood in that area. So that's really, the overview of what's going on in terms of the vascular response. So let's go back up here. So what we just talked about was this, again, the second line of defense. the inflammatory response, and then underneath that you have these two types, the vascular and cellular. We just went through the vascular. Does anyone have any questions about that vascular response before we move on to the cellular? Just type it up in the little chat if you do. Give you a second here. Is everybody following okay? Everybody's still there? And yes, okay. So to make sure I'm not all by myself here. All right. Oh, thanks, Haley. Okay, let's keep going then. So we've got that vascular thing out of the way. Not really, because it's going to come back and haunt us. But so I just want to highlight again that all of this is a non-specific response, right? It's happening no matter what kind of injury has caused this acute inflammation. That's what's going to happen. And it's a normal inflammatory reaction to anything that passes through that first barrier. And so remember we talked about, I'm just going to scroll back over here a little bit. If you look kind of down, don't worry about all of these really complicated things. Thankfully for your course, you don't need to know all those, which is wonderful. We talked about this clotting, this fibrinolytic system. That's this kind of thing that's going on here. You don't need to know any more about that. One of the other things that's being released here during this process are these things called kinins, and they're really just another kind of inflammatory mediator. Really, the one we're going to talk about is the bradykinin. Okay, so that's also being released during this kind of vascular response, where for the most part, we said that histamine was being released. We said down here, we said down here, remember we talked about, oh, the platelets are collecting, and then here the pro-inflammatory mediators like histamine and prostaglandin are released. Where do those come from? For the most part, those are coming from your mast cells. Mast cells are these big cells that are already floating around in your blood, okay? And what happens is when the inflammatory response is triggered, it triggers these mast cells to break down. You don't necessarily need to know any of this stuff down here. It's just helpful, I think, to know, okay, this is where it's coming from. It is helpful. So kind of, you might not get a question about a mast cell breaking down, but it's definitely going to help you answer the questions if you can have an idea of what's going on. So that's where that histamine is coming from the breakdown of the mast cell. Part of that process as well. You know what, let's go to the cellular focus a little bit more here. So you've got those bradykinins, you've got histamine, you've got prostaglandins, nitric oxide, leukotrienes. These are all these things that are being released from those initial phases of the response, or the inflammatory response. Part of what those inflammatory mediators do is they attract white blood cells to the site of injury. So they're pulling, or they're calling out to the white blood cells to come to that site. And that process of being called from where they originate, which is usually the bone marrow or somewhere in the lymphatic system, being called from those places to a site of injury, that process of them traveling, that is called chemotaxis. Okay, so you have these are chemotactic agents. This bradykinin, prostaglandins, leukotrienes especially are very strong chemotactic agents, and what that means is they attract white blood cells to the site. I can't remember a single one of my exams that didn't ask me what chemotaxis was, so it's good to really have a good understanding of what that is, but it's fairly simple. There isn't a whole lot of you don't have to go any deeper than that. That's it. So what exactly are they calling to that site of injury? Okay, and again, we're talking about our cellular response. Again, we're here still in this second line of defense here, but now we're talking, instead of about what's happening in the vascular and the blood system, we're talking about what's happening in the cells. Okay, so we've called those inflammatory mediators are calling these white blood cells. So I do find that people struggle a little bit with remembering, like, you know, what the white blood cells are and what they do. And so I just made this little chart because I figured, okay, let's just hit this really quickly. There's 5 main categories or main types of leukocytes. Again, when you break down this word, I know you guys know what a leukocyte is, but it'll help you later. Whenever you see cyte, we're talking cell, right? Whenever you see leuc, we're talking white. So in this case, we're talking white blood cell. Pretty simple. Oops, sorry about that. And so, just going to mute my computer there, but some other students questioning. So let's talk about monocytes. Monocytes make up about 4 to 8% of the white cell count in your blood. Their main job is phagocytosis. We'll talk about that later, but it's basically just the engulfment of whatever foreign particle or pathogen has entered through that first line of defense. It's going to engulf it, so we call that phagocytosis. Neutrophils, these are your main fighters, really, especially in terms of like a bacterial infection. They make up about 75%. It's a very large percentage of your leukocytes. These numbers, guys, are going to be different depending on what textbook you read. So you don't need to memorize them. Just knowing that most of your white blood cells are neutrophils. And that those neutrophils perform phagocytosis. We'll talk about that later. You also have then, so these two white blood cells here are non-specific. Okay, they will fight. They're phagocytic. They're going to attack and clean up anything that breaks through that system. Whereas these other 3 are a little bit more specific. So your lymphocytes, these make up anywhere between 16 to 45% of your white blood cell count. Your lymphocytes, their main purpose is creating an immune response. So you remember learning about it's like helper T cells and B cells. Those are types of lymphocytes. These lymphocytes are playing a role here. Okay, they're playing a role here in this third line of defense, this specific line of defense. So in terms of the cellular response here, they're not involved. Okay, we're really focusing on these macrophages and monocytes, macrophages, and neutrophils. Same with the eosinophils and basophils. There's a lot less of them. Again, these numbers are going to change depending on what you read. The idea is that there are a lot less of them, and they're much, much more concerned with dealing with an allergic response than they are with, you know, a non-specific pathogen or injury to the body. And I know you guys know this, but our normal white blood cell count should be somewhere between 4 and 11. I think that your slide said like 4.3 to 10.8 or something. I said this to the other group as well. Don't panic trying to memorize those numbers. You just need to be able to recognize what a very low count is and what a very high count is. And you know a count of 2 is low and a count of 15 is high. You don't need to be worried about like, oh, what if the count is 10.9? Right? We're not really worried if the count is 10.9. You guys know that. At least I never have been in the ER. That's actually probably not true if you're dealing with chemo patients or so on, but for the purposes of this lesson, we're not worried about that at all. Okay, so let's just go over here to this. So these, I remember I said that these monocytes and macrophages here are phagocytic. They perform phagocytosis. So what is a phagocyte? Phagocyte is any cell that's capable of engulfing and absorbing some kind of particle or bacteria that has crossed through that initial defense system and has entered the body. anything. In this case, we are talking about monocytes, which turn into macrophages, and neutrophils. And when we refer to this kind of the process of this kind of these cells performing phagocytosis, we refer to the mononuclear phagocyte system. Okay, and basically all this is a system of monocytes, macrophages that work in the body against those pathogens. For example, you have actually here. Let's just look at this, because one of the things that was highlighted in your slides is the difference between a free macrophage and a fixed macrophage and a free macrophage or monocyte. So first off, monocytes originate in the bone marrow. Okay, this is where they're kind of born. They travel through the blood to, let's say you've got something going on here. They travel through the blood to the site of injury. When they enter into, so they're in the blood system right here, but when they enter into the tissue, they turn into macrophages. Okay, so they originate as monocytes, they travel in the blood. When they get to the tissue they're supposed to be affecting, they turn into macrophages. Okay, those are your free monocytes, and they're free because they move through the blood and they move through connective tissue in order to find their way to where they are actually needed. There are also some macrophages that are fixed. What that means is that they already exist in the liver, in the spleen, I believe, bone marrow. There are some that stay in the bone marrow. There are some in the lymph nodes and lungs. They're there, these macrophages, and they don't move. They don't go into the blood system. They're there to work against anything that enters that system. But when you have this chemotaxis going on right here, because there's been some kind of injury, these fixed macrophages that are in the lungs or in the liver, they are not being pulled to that site. Only the ones that are in the blood system, these free monocytes here, are going to be pulled. Okay, so the difference really is that a fixed macrophage doesn't travel in the blood. It stays where it is and attacks whatever comes to it. A free monocyte travels through the blood or the connective tissue and becomes a macrophage, and then performs its job of phagocytosis at that point. So let's move on here. Let's talk about a little bit more of these monocytes and neutrophils. So there's kind of an order to this and how this inflammatory response happens. Again, we're still in that second window there, that second stage of the inflammatory response. So your neutrophils are the first to arrive. They arrive at the site within 6 to 12 hours. They have a relatively short life. They only live like 24 to 48 hours. Basically, they perform their phagocytosis and then they die. And they leave behind them dead neutrophils, digested bacteria, and debris. And that is what makes up pus. We'll talk about that again in a little bit, so don't worry about it right now. But the idea is that it comes quick. Those neutrophils come very quickly. They're the first to show up. They attack, and then they die off. And yes, of course, they're pulled there by chemotaxis. They're all pulled there by chemotaxis, right? Your macrophages are your monocytes, on the other hand. So your monocytes are the second to arrive. They will arrive within something like 3 to 7 days. Sorry, I should have put that in there, but 3 to 7 days. They enter the tissue. When those monocytes, again, they enter the tissue, they become macrophages. Now, some of those monocytes, so let's look there at that tissue of injury again here. Some of those monocytes, yes, are being pulled there by chemotaxis. But let's say the injury is here. It actually is, the injury is to the liver. Some of those macrophages are not necessarily being pulled by chemotaxis. They're already there. But some of them are, right? Some monocytes are coming and they're going to turn into macrophages. And of course, their neutrophils are coming. And that's all through chemotaxis, right? These macrophages actually have a fairly long lifespan. They can live for weeks and they multiply. And why that's really great is that they will clean up kind of the mess that these neutrophils have created. Yes, they are definitely cleaning up, or sorry, engulfing, you know, what's there, the pathogen or the injury or what have you. But they also will do a long-term cleanup of kind of the pus and debris that's been left over by the neutrophils, okay? So remember we talked about, oops, man, it'd be really helpful if my computer stopped freezing. We talked about these white blood cells here. You have probably all seen blood work come back, and you know that when we are concerned about a patient having some kind of infection, yes, we are looking at their white blood cell count, but we're also looking at neutrophils. Neutrophils are a really, really important indicator of infection. And part of what we see a lot, I was telling the other group, I worked in the ER for a little bit at Toronto Gen. I did a placement there. I did a placement there. And this shift to the left would happen a lot, and I'll explain why. So when there is some kind of pathogen, let's just say it's pathogen at this point, okay? Neutrophils are going to that site and they're fighting and they're fighting and they're fighting, but they don't live long, so they're dying off, right? As they die off, those neutrophils are being replaced by other neutrophils that are being created in the bone marrow. So we kind of have these two, not kinds, but you have mature neutrophils and immature neutrophils. Your mature neutrophils, you'll see this on blood work as segmented neutrophils, and your immature, you'll see it on blood work as bands, okay? So what happens is eventually all of those mature neutrophils that are sent to the site are being used up, and the body can't keep up, so it starts sending out whatever neutrophil it has created in the bone marrow, and oftentimes those are immature. They're not actually ready to go to the site yet. And so those immature neutrophils or bands are being sent out into the blood. When that happens, you will see those numbers on your blood work go up, the bands. So you'll see neutrophils go up, of course. You'll see the band numbers go up as well. And what this indicates is that there is some kind of more severe infection because your body isn't able to keep up with sending and creating and sending the neutrophils it needs to fight whatever that thing is. We call this whole process of immature or band neutrophils being sent in place of mature ones as a shift to the left. When your blood work comes back and you've got tons and tons of bands, it's a shift to the left. This is something that comes up on almost every test, so just make sure that you understand that. I'd be surprised if it didn't come up. Okay, so again, we've talked about these macrophages. One of the cool things that macrophages can do is they can actually join together to make this giant phagocyte. And so macrophages will create this like multinucleated cell that can engulf larger particles. So something there that's not, it's too big for one macrophage to kind of engulf. They will join together and create this multinucleated cell that will, instead of digesting it, it kind of walls it off into this, uses collagen to wall it off into a granuloma, really, that's where. And if you look here, I think your slides talked a little bit more about TB of the lung and how a granuloma in the lung, that this is how that happens. Those larger particles are engulfed by this giant macrophage that's made up of a bunch of macrophages, and instead of digesting, it closes it off And that's why we end up with, in TB specifically, but also in any case where we've created a granuloma, with this kind of chronic inflammation, right? Because it's not fully digested. It's going to keep triggering and triggering and triggering all of that inflammatory response. Okay, so we actually can move on to, just want to go back over here for a sec, this nice chart we were looking at before. We're going to move on now from everything we were just talking about, which was here in the second line of defense, in that non-specific. We're going to move on now to this third line of defense. Whoops, this would be really helpful if my computer stopped freezing. This third line of defense here, and I'm just going to pull over here. That are these white bloods. That's what these white blood cells that we talked about earlier, the lymphocytes, eosinophils, and basophils. These are the white blood cells that are concerned with the immune response. It's no longer just the inflammatory response. This is the immune response now. Lymphocytes arrive quite a bit later. They're part of this third level, and they create or fight against specific pathogens. So just think about, when you see lymphocytes, just think immunity. We're talking about specific immunity to specific pathogens. And again, when you see eosinophils and basophils, just think, mostly what we're talking about is the body's immune response to an allergen or allergic reaction. We'll talk a little bit more about that in the coming weeks. We won't worry about that right now. I'm just need to make this a little bit smaller here. Okay, so remember earlier where we talked about, I'm just gonna slide over. We talked over here about how all of this vascular response, over here that's happening, and all these pro-inflammatory mediators that are being released all here, and the fact that all of that blood is being pushed out into the tissue, and how that makes the blood inside the vein viscous, right? We talked about that. Whoops. Sorry. So I just want to, sorry about that. So part of that is, yes, this nitric oxide that's released during phagocytosis. We're going to talk about that in a minute. The nitric oxide from those pro-inflammatory markers and so on. So when you see nitric oxide come up, sorry guys, I know I have a better spot here. We talk about nitric oxide. Again, I've kind of shown you, where it's coming from, right? You can see kind of where it's coming from. You know what? I'm sorry. I'm going to back up just for a second here, because we'll talk about it in a second. The point is that this blood flow, I've moved that kind of blood over here so that we can talk a little bit more about it. So again, I've drawn this kind of cross section of the venule. Okay, so this is the endothelium. This is the inside of the venule. So you remember that through chemotaxis, right, which is the calling of those white blood cells by prostaglandins and leukotrienes and what have you, histamine and what have you, those white blood cells have been called to the area of injury. But what happens is white blood cells tend to hang out in the center of the venule. We call them axial. They're axial white blood cells. And what that means is, you could see in this picture here, they're all kind of hovering. They're kind of hovering in the middle here, right? And so what's really cool about this viscous blood, this whole idea that the blood has become thicker. So that blood flow through the area has slowed. It's become viscous. So you've got a higher amount of red blood cells kind of in here, right? What happens is those red blood cells push the white blood cells to the sides, okay? They push them over to the sides like this. And when they do that, we call that margination. I'm going to go through this again, so don't worry. But that they push them to the sides, and we need them to the sides because your injury, your injury is out here, right? So we need to get these white blood cells out into the tissue. Definitely not going to happen if they're hovering in the middle of the venule like this, right? So we've now the white blood cells that have, the red blood cells that have accumulated there through the buildup of nitric oxide and through the fluid being pushed out, have now pushed these white blood cells to the edges. So they're all sitting kind of here now. They're marginated. And then you can kind of see, I really like this drawing. This is kind of showing you that here. So here's your axial white blood cells. Your white blood cells are stuck in the middle of the tube like that. Okay, you've got this increase in white blood cells or red blood cells because of the nitric oxide and the viscosity and all that we just talked about. It's pushing those white blood cells now to the sides. This is called margination right there. It's called margination. But now we need to get that blood out. And so we need it to go, I'm going to skip these two phases for a second, okay? We need it to go through, remember those gaps we made in the capillaries earlier? We need those white blood cells to go through those gaps and out to the tissue, out to that site of injury, right? So how does that happen? This is where things do get a little bit confusing. I'm going to try to break it down as simply as I can. Those cytokines, there are cytokines that are released during the initial inflammatory process, okay? I know the word cytokines hasn't come up yet, so it seems like it's coming out of nowhere. But they've been, throughout this entire process that we've been talking about, we just haven't mentioned them, but they've been being created and being released. Cytokines, you don't need to know their names. They're things like interleukins, tumor necrosis factor. These are all they're very important parts of the inflammatory process, but they all kind of have their own little role. And thankfully, you don't have to memorize them all. So all you really need to know is the word cytokines, and that they are molecules or parts of the inflammatory process. Okay, those cytokines, part of what they do is they cause the white blood cells to express or create these things called cellular adhesion molecules. And so what those are is, let's say this is your white blood cell here, okay? You start to express or create these little molecules up on the side of the cell, like so. But it also creates or expresses those molecules. So that's the cell, right? This is the vein. It's inside of, like, it's inside the vein. Sorry, I'm not an artist. So it also will create those molecules here on the endothelium of the venule. These, again, are selectins and integrins, or cellular adhesion molecules. Okay, what those cellular adhesion molecules basically do is they cause the white blood cell to become sticky and to stick or adhere. That's why we call them adhesion molecules, or adhere to the endothelial wall. So if you scroll down here, remember we talked about, okay, the white blood cells have now been pushed to the side, or margination has occurred. How do we get them out of these gaps into the tissue? That's where these selectins and integrins play a big role. If you look down here at this kind of little drawing here, you can see this. Say this is your little neutrophil here. You've got these selectins and integrins. Or let's say selectins first. Kind of pull it to the side, and then. So as you get, so here and here, attracted here and here, right? It rolls. This white blood cell rolls, and it keeps rolling and sticking and rolling and sticking and rolling and sticking, and then it kind of flattens out a little bit, and that's how it finds its way through that gap in the in the endothelial layer that we talked about earlier. So that's kind of I feel like the selectins and integrins and that rolling and margination is really the most confusing part. So if you can kind of get a handle on that, you're doing really well. The only other thing I wanted to highlight is that this process of those white blood cells escaping through those gaps is and moving to, let's say, the site of injuries here, and moving to the site of injury. This whole process of going through the wall and to the injury is called diapedesis. Okay, it's a part of extravasation. Extravasation just means outside of the vein, right? So it's moving outside of the vein. I think your slide also called it emigration, right? It's part of the emigration of the white blood cell. They're all kind of referring to the same thing. It's just that diapedesis and margination are just really more specific to those specific aspects of emigration or extravasation. So again, you've got your margination, which is the pushing of it to the sides, and then your diapedesis, which is it going through the gap and out, through the gap and out to the site of injury. Now, I think there was a couple more. So I don't know that, I'm going to go through this kind of process of phagocytosis really quickly. I don't know if you guys need to know it, but just in case it shows up, because it wasn't really on your slide, but so imagine this giant thing here is your phagocyte. So whether it's a macrophage or a neutrophil, you can imagine whatever you want. Again, it's been called to the site of injury by chemotaxis, by the chemotactic agents like your leukotrienes and prostaglandins and bradykinin. So now it has gone through this whole process of margination, through the process of diapedesis, and it's now landed at the site of injury. Okay. So the first thing that's going to happen is that microbe or particle there that we're fighting against. Let's call it a bacteria for right now. Okay. So this microbe particle. The first thing that's going to happen is that the receptor sites on the phagocyte will attract basically the microbe, okay? And the microbe will move in and become kind of sticky and stick to the phagocyte and then become engulfed in the phagocyte, okay? This process actually has a name. Just this process of the microbe kind of being engulfed, this first, like sticking to it and becoming engulfed at first, is called opsonization. And that's because there are these things called opsonins that kind of work as part of that. You don't need to worry about it. The only reason you need to know the word opsonization is for later when we talk about complement proteins. Okay, so that's the first thing that happens. Once it's kind of, you can see how it kind of engulfs this phagocyte, like engulfs that microbe, right? And it closes up around it and creates its own kind of little like pseudocytoplasm, right? It's almost like its own little cell now with a cytoplasm and the microbe as its nucleus or the middle. And what happens is these little digestive enzymes called lysosomes are already inside of the phagocyte. Okay, those join up with that pseudopod or that pseudo. We actually call it that pseudopod. We actually call a phagosome at that point, right? So these lysosomes join up, kind of, and make one big. You can't really see it here, but imagine that forms one big, what they call a phagolysosome. Okay, and in there now you don't just have this pseudocytoplasm and the microbe. You have these little digestive enzymes that are inside of the lysosome, and that is what attacks and breaks up this microbe inside of that little cytoplasm. So the next stage here we have those kind of broken up pieces of the microbe inside of that phagolysosome, and it's digesting, and then whatever's left over here, like there are always pieces and parts that can't be fully digested, those will then be released back out of the phagocyte. And this is, again, those waste products that we talk about that will end up being a part of your pus or liquefaction or what have you. Okay, I'm going to skip that part there because we're almost out of time here. I just wanted to hit really quickly, I wanted to hit these complement proteins. This is not something that, it is very complicated, the complement system. It's a giant cascade of complement proteins that are affecting each other and affecting each other and affecting each other, and they're creating all of these responses all the way down this cascade of chain. Thankfully, you don't have to know that whole cascade. The only thing you really need to know about the complement system, is that these complement proteins are released. You don't even need to know what they are. They have names like C3A, C4A, C5A. They're mostly released by the liver. They're normally inactive. They're floating around in the blood. But when cell destruction occurs, they will also stimulate histamine release. So what does histamine do? Again, it's going to, anytime you see histamine, you're going to think increase in vasodilation, increase in vascular permeability, right? So that release of histamine caused by these complement proteins is going to complement what's already happening in the immune system. That's why we call it a complement response or complement system. So really, the most important things, other than the histamine release, that it does is it increases or complements opsonization and phagocytosis. And again, opsonization is this ability of the like the membrane of the white blood cell or the macrophage or what have you to attract those microbes, right? So that then it can then engulf them and go through this whole process of digesting them, okay? So complement system, great for opsonization, helps with phagocytosis, and again, it's going to complement this whole inflammatory process by releasing more inflammatory mediators like histamine. The only other thing that that I'd like to go through really quickly before I let you guys go, I'm just gonna make this a little smaller, is this kind of arachidonic prostaglandin leukotriene thing. So in your notes, this was like a giant paragraph. It was also like on your slide, it was quite a large paragraph, and I'm going to try to explain it without writing, like just trying to talk it through, and then we'll pretty much be done at that point. So again, we know that prostaglandins are these inflammatory mediators that are released during the inflammatory process. They increase, again, something very, very similar to histamine in that they increase blood flow, right? They cause vasodilation and increase in cap permeability. They also cause chemotaxis, but they're a large part of the reason why there is so much blood flow and edema at the site of injury, okay? Prostaglandins. The other thing that prostaglandins are responsible for is pain. So prostaglandins mixed with bradykinins. Remember we talked about those bradykinins are created way back in the vascular at the beginning of the whole process, right? And throughout the whole process. Prostaglandins and bradykinins together result in pain, okay? So here's down here, we kind of have where these prostaglandins are sitting in our system. How do they get there? One of the biggest kind of creators or releasers or whatever of prostaglandin is this whole arachidonic acid cyclooxygenase pathway. And don't worry, I'm going to explain it. It's actually not, it is complicated, but what we have to know about it for this class is not that complicated. So you remember how the outside of all of your cells is created by a phospholipid bilayer, right? So your blood cells, most of your cells are phospholipid phospholipid bilayer. So cellular injury causes this this phospholipase A. You don't need to know the name of that at all, but it causes this lipase to break down those phospholipids into arachidonic acid. This is a good thing to remember. It may or may not show up on your test, but it's really good to understand it anyway. So again, your phospholipid bilayer has been broken up into arachidonic acid. Through this cyclooxygenase pathway, and again, this is a very complicated, like, molecular chemical thing that's going on that we don't have to know about. It creates or results in prostaglandin. It does this two different kind of pathways, splits into two different pathways. You have one pathway over here that uses the COX-1 enzyme to break up this arachidonic acid into prostaglandin and thromboxane. I wouldn't worry a whole lot about thromboxane, to be honest. It may show up. I don't want to say don't look at it, but I wouldn't focus too much on it because they can only ask you so many questions, and it's not really what we're focusing on here. So the COX-1 enzyme, right, is breaking down this arachidonic acid into thromboxane and prostaglandins. And again, prostaglandins are responsible for all that stuff we talked about earlier, right? There's a second pathway where the arachidonic acid is broken down by COX-2 enzyme into, again, prostaglandins. Now, there's all kinds of, like, other ways of classifying them in terms of where these COX-1 and COX-2 are located more and what, but I don't think that you need to know that for right now. I think just understanding this is kind of how our cells, or phospholipid bilayer of our cells, is broken down into this arachidonic acid and then further broken down into prostaglandins, which are going to have a huge effect on our inflammatory process, right? What's interesting is that I'm sure you know that your NSAIDs, certain NSAIDs block COX-1 or COX-2, right? And so remember when you're studying a pharm and it'll be like, oh, it's a COX-2 inhibitor or a COX-1 inhibitor. This is what it's talking about right here. This is where those medications are working. Your corticosteroids, like your general corticosteroids, your Dex and so on, those are working here on this action here, this phospholipase, so that it's not breaking down here, preventing it from breaking down here, which means it's not going to end up being prostaglandins. The NSAIDs are working here and here. There's a lot of arrows, sorry, to ensure that it doesn't break down into prostaglandins. Okay, so I think those are like the main things. There were a few more slides here that there was just no way for me to get through it all. Like I know I'm already over time, I'm sorry. You'll just have to go through the slides, but this stuff is like, it's not patho, it's just kind of looking and knowing, okay, this is the process of healing or the process of inflammation, or the phases of healing, phases of regeneration and repair. You guys can kind of look through this and make sure you break it down and have an idea of how to answer those questions. There definitely will be a couple of questions on, or at least one question I would think, on these phases of healing here, so just make sure you know them. The other thing is this lovely pathogen thing that we've all seen since the beginning of our RPN years. Just make sure you have an idea. I'm sure that most of you or all of you already do, but just since this was here in your notes, make sure you go over it and you know what's a virus, what's a bacteria, what's fungal, what we use to fight those, right? We use an antiviral, not an antibiotic, to fight influenza because it's a virus, and so on. So as long as you can get through, kind of get through those on your own, I think that you will be okay. Does anybody, before I head out, does anybody have any questions about anything that I went over? I know it was a lot. Oh, you're so welcome. You're very welcome. I'm glad it's helpful. Thanks, Haley. So I'm here. I did give my email out to the other group, so I'm going to put it in here for you in case you... Oh, that's not wrong email. Sorry. This is my George Brown email. In case you have questions or I don't know if there's anything I can help you with. I'm not on a whole lot, but I'm around. I only work 10-15 hours a week on this, so I'm not always there. But okay, thanks so much for coming out, you guys. I'm super impressed that like between you and the group before, we've had like 35-40 people, so that's really awesome. So I will see you again next week. Good luck. I think you guys are doing osteoporosis next week, so we'll talk about that then. We'll see you guys then. Thank you.